So, Mr. Priya, am I audible? Am I audible?
You're audible, Sridevi.
Thank
Say
you.
some nice
Thank you
things
so
about
much.
me, even it doesn't have to be true.
Yes. Yes, sir. Thank you so much, everyone, for joining us for today's session. Indeed, a pleasure to see so many faces willing to learn and be with us during this journey to understand palliative care. Thank you so much for choosing this program. So today we'll start with the first session by Dr. Rajagopal about the introduction to palliative care. So I know that some of you might be knowing him, but it's my responsibility to introduce him to the group. He's the director of WHO Collaborating Center at Trivandrum Institute of Palliative Sciences, which is a WHO Center for Training and Policy on Access to Pain Relief. And he is the founder chairman of Palliative India. I think there are so many points in the slide, but I will not be reading that. He is teacher to many palliative care healthcare workers in the country, and he still continues to be a teacher. Thank you so much, sir, for joining us for today's session. Over to you, sir.
Thank you, Sri. Sri and Sri, thank you. Hello, everybody. I don't know, I think I missed it in the ground rules. We have to start by everybody giving me a smile. Very good, very good. I noticed that a few people have not given me a smile, very frugal with smiles. Prasanna Rani, no smile for me. Some faces I can't see. Okay. Hi, everybody. We are on a journey starting today. A journey that can change your professional life. A journey that can change your professional life so much so that you get much more pleasure from doing your work, much more satisfaction. Which also means that there may also be some pain. We are offering to connect with people in a way that not everybody may have. We are choosing to see the person about what he or she is, but what his or her own suffering is. But at the end of the travel with every patient and family, you will feel much more satisfied. That's why so many people, including Sri Devi, Sri Priya, and all of us, I know me, we are all here for a long time. So thank you once more for joining the course. And I'm going to introduce the subject to you. And you can either raise your hand electronically to ask a question or a comment. I hope we can make this interactive. Or you can also write questions or comments in the chat box. Sri, I hope you will monitor the chat box and let me know if there are any comments or questions.
Sure, sir, will do.
So, I understand that about a dozen of you have had some palliative care experience already. And also that the majority of you are new to palliative care. So to the people who are already experienced in palliative care, please forgive me, this is only in the introductory session. I have to go down to the basics. Those who have experienced, the dozen of you who have experienced the subject already, you are free to, you are welcome to sleep during the session, no problem here. But the others, please be with me. And also, I also understand that maybe half a dozen or more of you are from countries other than India. We speak the language called Indish. I think you were mistaken. You were told that the medium of instruction will be English. This is going to be Indish, which is the English language filtered by the Indian tongue. So people from other countries may find it difficult. Indonesia, Kenya, Bangladesh and Sri Lanka may more follow it more. But others, please raise your hand if you don't follow me and want me to repeat anything. Okay. So let me start with a question. You may have, apart from those who are already experienced in palliative care, may have very impressions about what palliative care is. Suppose I say palliative care is essentially for people with terminal cancer. What would you comment? You would agree or you won't? Priyanka doesn't agree. Oh my God, I asked the first question and it's all disagree. Very excellent. I'm glad. I'm glad that we are starting from something nice. Of course, it is not. But let me share my screen and start with the presentation that I have ready for you. There are many definitions. I myself later on will be bringing up the WHO definition, which is different from what you see here. Having said that, I must also say that this is something that I would please request you to remember. The first sentence. Palliative care is mitigation of serious health-related suffering. Mitigation would be prevention and treatment. Palliative care is the prevention and management of serious health-related suffering. And between all these countries to which we belong, except for UAE, we are all here from low or middle income countries. But what's common between low and middle income countries and UAE and the Middle East is that access to palliative care is universally bad among every participant's country in this course. And between most of these countries, 51 million people are in serious health-related suffering every year. Sri Priya will be sending you the PPT, and I have given the reference here. I would strongly recommend that you read at least the executive summary. It's a long document, some 60-something pages. The executive summary itself is 5 pages. I would request you to read it. It was a good introduction to the subject. So, friends from India, in our country alone, somewhere between 7 to 10 million Indians are in serious health-related suffering, which is our business, our collective business. It is the business of every healthcare provider. In India, the duty of care of the healthcare provider is defined as the duty of healthcare provider is to mitigate suffering more than anything else. To cure sometimes, to relieve often, and to comfort always. There exists no exception to this rule. And while not every doctor or nurse may agree with this, we in palliative care totally take this to heart. And this is first our omission in healthcare, that we are not relieving the suffering of people like him. But there are also some more worse things that we do. In India alone, 55 million Indians are destroyed by catastrophic health expenditure. For those from other countries, if you go to the World Bank website and look for catastrophic health expenditure, you will get an idea of what's happening in your own country. And I suspect that the destruction of families is worse than you imagine very often. Friends in India, 55 million is more than 4% of our population. We are supposed to be providing health. Health is physical, social, and mental well-being. Listen, we are supposed to improve physical, social, and mental well-being. And look at what we are doing. Of these, 38 million Indians are going below poverty line. And that means we are destroying the health of those people and the next generation also. Something for us to remember, when we pick up that pen to write a prescription, before writing transdermal fentanyl or before prescribing gabapentin, you will stop to think, can the family afford this? Is there an alternative that is less expensive? When I asked whether it's terminal cancer, management of terminal cancer, you all disagreed, and I wholeheartedly applaud. There can be different evaluations, but this comes from the Worldwide Hospice and Palliative Care Alliance. I thank Dr. Stephen Connor for permission to use this image, which shows the breakup. Please remember, cancer and other cancers and leukemia together account for only 28.7% of all palliative care needs. Remember that. And please remember, something that you may not have thought is so prevalent. 12.2% of dementia. So this is not something for some diseases alone. When my time comes, if I am suffering, you give me palliative care. As simple as that. Particularly in India, we have the data. I'm not sure about other countries. More than 29,000 people kill themselves because of health-related suffering. Health-related suicides are about 1/5 of all the suicides in the country. Something for us to think about. I have seen enough scars around the neck. I have seen enough slashed wrists. I do not want to see many more. So what do we do? Again, this is worse in India than than in Kenya. I'm not sure. A growing problem in India during the last quarter of a century is the inappropriate end-of-life care. Hey, will somebody read it out for me? Who is going to read it out for me? John Babu, could you please read it out for me? Unmute and speak. From Dr. Sankha Mitra, a Bengali oncologist and palliative care enthusiast.
In India, the poor die in misery of neglect, the middle class die in misery of ignorance, the rich die in misery of intelligence. No one gets a pain-free and dignified death.
Well, maybe we can say that maybe not no one today. When Sankamitra wrote it, it may have been close to no one, but maybe less than 2% of people in our country get reasonable, rational end-of-life care. And this infliction of suffering is totally unjustifiable because that causes enormous suffering and financial destruction of families. So these are all things that we will talk about in the course. I am sure there will be a session on end-of-life care. There will be detailed sessions on pain management. But those coming from India, please note that there is this position statement. You might look at this. It will be an interesting document published in the Lancet. We have a recommendation within the country by a conglomerate of more than 350 cancer hospitals in the country, which say, do not treat patients with advanced metastatic cancer in intensive care unit unless there is an acutely reversible event. And I would say the same thing. Okay, it's National Cancer Grid, so they talked only about cancer. But I would say the same thing about dementia or other neurological diseases. If they are incurable and progressive, I don't know how many of you would want your loved ones to live for 2 weeks more, suffering every minute. That's cruel. I think we need to be compassionate to people who are dying, especially our loved ones. We should not be so selfish as to think, I can't live without my mother. Let her be alive for 2 more weeks on a ventilator. We should be thinking, my mother must be suffering so much. She deserves a good life as well as a good death. Here is the official definition of palliative care by World Health Organization. I did not show it in the beginning, and I said it is mitigation of serious health-related suffering, just because this is too long and too old. This is 21 years old. But some things are very important. The only questionable thing is the wording life-threatening illness, because life-threatening may be interpreted differently by different people. Otherwise, it's all fine. It's too long. That's all the only problem. So, who else is going to read it out more for me? Shagufta, Nooril, would you be so kind as to read this for me, unmute and read it for me?
Palliative care is an approach that
A bit louder, please.
Palliative care is an approach that improves the quality of life of patients and their families.
Wait. Shagufta, noted 2 important points there. It's about improving quality of life. And not only of the patient, but also the family. Let us never, ever forget that. The family very often suffers a lot, sometimes more than the patient even. Thank you, Shagufta. Sorry for interrupting you. Continue.
Facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual.
Very good. Thank you. You notice that the prevention and relief of suffering comes here also very clearly. And for that, the management would be taking care of identification of the problems that are physical, pain, breathlessness, vomiting, constipation, bad ulcers, fungating wounds, paralysis, anything. But also psychological, social, and spiritual problems. Prevention of problems also. So these are all things to be taken care of. And the World Health Organization definition adds a footnote. Hey, somebody please help me. I'm trying to save my vocal cords. They are very, very tired. I never stop speaking. Who is going to help me this time?
What is palliative care, Sir Satyamurthy?
Thank you, Satyamurthy. Yes.
Applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage distressing clinical complications.
Thank you, Dr. Murthy. Important points. Did you notice? applicable early in the course of illness.
Or at the end.
Such as chemotherapy, radiation therapy, antiretroviral therapy, or other symptom control, whatever. But early in the course of illness. Thank you. So that's an important point. Earlier, in the 1986 definition, they said a distinction. Curative care stops and then palliative care starts. This is a no, not acceptable. Palliative care starts when suffering starts. Disease modifying or potentially curative treatment continues. Along with that, palliative care goes on. Maybe when the patient is close to death, there may be practically no disease modifying treatment, but palliative care takes greater importance. And because palliative care is for families also, the care doesn't stop with the death of the patient. Bereavement support continues for the family. Any comments? So, with that introduction, we said it has to start early. What do we have to start early? For example, we have to treat pain adequately. In India, pain relief reaches less than 4% of the needy. That Lancet Commission report does give a breakup for different countries so that you can look up your own country's statistics. But in all our countries, the access is very poor. Now, I'm not going to the details here because Sridevi then will be very annoyed with me because somebody else is going to do pain management in detail later. I'm not going to it. But I'll nevertheless still point out that what is common for most of our countries is that strong opioids for moderate to severe pain is not accessible, available. And because of that, something else very bad happens. What do you mean by non-opioids? Paracetamol and other NSAIDs mostly, right? Okay, there may be a few others like Nafopam, etc., not very important. But in the absence of opioids, what we give is non-opioids. You may not give enough information about it. And what really happens is people swallow more than you prescribe. You have prescribed one ibuprofen 3 times a day. Because the pain is so bad, they take another and another. They overdose themselves and end up with renal dysfunction also. So, dear friends, all of us, we must accept this responsibility. Not only to treat patients coming to you with medicines available in your institution, we must be advocates for the patient to find out why strong opioids like morphine are not available and take remedial measures. But for every symptom, compared to what you have learned in your textbook of medicine long time back, or in your textbook of surgery, the management in palliative care would be different. For example, suppose you have a patient with advanced metastatic cancer, lung cancer, coming to you totally breathless. The person is breathing like that, turning blue gradually, cyanosis developing, great distress. Where will you treat the patient? Will you treat the patient in the intensive care unit or in the patient's room or general ward? Many of our hospitals do not have specialized palliative care units. Where would you treat them? Nivedita, where would you treat the person? Here you still inaudible. I see that you are unmuted. No, Nivedita is not audible. You can put it on the chat box. Tinu? Dr. Tinu Dambani? Where would you like to treat the
mostly
patient?
in the intensive care units if the patient is gasping. And,
Yeah. No, there will be, Dr. Tinu. Nivedita also says ICU. Nivedita, now just stop for a second. There will be another session on end of life care, but I want to use this example to show you what is the objective of palliative care. Imagine myself in that position. I don't want to talk about you or your family. It may be more painful for you. But I am at my age, I can see disease and death right in front of me. When I am eventually dying of an incurable illness, what is important for me? What is it that's attractive for me, my well-being, my quality of life, Tinu, my quality of life? What will be good for me in the ICU? The air conditioning, 17 degrees, me freezing, the lights on 24 hours a day, about 73 machines bleeping, bleep, bleep, bleep all around. No human beings, only masked and capped, weird creatures walking around. Do you know what would be important for me on that day? Certainly, I need to be comfortable, right?
yeah,
What else?
definitely.
My pain needs to be treated. My breathlessness needs to be treated as best as possible. What else would be important for me?
To be as close to the family.
Right, right, Nivedita? What could be more important than me for that? Now, this disease of intensive careopathy is a recent origin. It started only in the last quarter of a century, only since the late 1990s. Till then, intensive care was only for those who were salvageable, whose condition could be improved. This disease is new and it is particularly bad in India. I'm not sure. I suspect from what my friend Sipora Ali tells me, this doesn't happen so often in Kenya. But I don't know about the other countries. What I would like you to do for me is, for heaven's sake, keep me out of that ICU.
Okay.
If I have a fracture, if I have a traffic accident and fractured 8 ribs over here, it's different. Keep me in the ICU.
Okay.
Then you can get me back to life in a week. Here it's pointless. I want my family by the side, Trinu, as you said. And don't tell me false reassurance like, don't worry, everything is going to be okay. That's silly.
Yes.
Who stops worrying because somebody asked them not to worry? And I know everything is not going to be okay. That's okay. But what would be reassuring for me? Shalu? Priyanka? What would be reassuring for me? If you are on, yes, Shalu.
I want to be with my relatives
Yes.
for the rest of the time.
Yeah, that you have already done. Okay.
Yeah. And I don't want any invasive procedures.
Okay. Very good, Shalu. Shalu, if
Yes,
you are
sir.
my doctor,
Okay.
in addition to all that, what I also want is the feeling that you really care for me.
I will ask the patient.
If your eyes show compassion, and if I am breathing like that, if you hold my hand and say, we are going to look after you, we will do everything to make you comfortable. Oh my God. In a hospitals where most people are impersonal, it will be such a relief to find a human being. So this is what I would do, Shalu. I will assure them we are going to look after you. We are going to try our best to make you comfortable. I will give oxygen for 10 minutes and see if it improves the situation. If not, I'll take it away. I'll tell them we are going to try it. If it makes you feel better, we'll continue it. If it's a nuisance, you see some people taking the oxygen mask off. If it's not helping with the well-being, it's of no use. What may certainly help me in that situation would be corticosteroids to reduce the peri-tumor edema and low-dose morphine. Low-dose morphine is now treatment of choice for terminal breathlessness. Quarter of a century back, it was considered contraindicated. Now it is a treatment of choice. A very dear teacher of mine who had been on oxygen for 2 months, we started her on small dose, 2.5 milligram of morphine 4 times a day. In 2 days, she came off oxygen because it makes the breathing easier and thereby the remaining lungs more efficient. So my intention is not to go into details of management of breathlessness. I just wanted to say that the management becomes different in the context of an incurable advanced illness. I'll skip that. We have already mentioned that. So I was talking about a couple of physical symptoms. Similarly, you will explore. You look very anxious. Tell me what's happening. This is not standing down and looking down at somebody, sitting down, maybe holding your hands, maybe wiping a tear. Obviously, you are very sad. You want to talk to me about it? And when you are kind and your voice shows compassion, they'll come out with things that they have not even told their family. Then you are able to help them. It is not only about starting antidepressants or anti-anxiety medicines. It's also about listening and giving companionship. Many people are isolated emotionally, even from close family. When somebody goes and says, eat, you must eat more. The person with no appetite feels, no one understands me. They become lonely. And spiritually, it's about meaning of life. One of my classmates is in advanced illness, several in advanced illness at the moment. I visited one of them yesterday. And he was all the same saying, what's the point of me being alive? I wish I were dead. And this was said 4 or 5 times, and his wife was getting angry. I did not say anything about God or religion or anything. I know he's a religious person. But I asked him to tell you, what was the happiest time of your life? And he started off about how he had learned so much of orthopedics in the West, how he was the first to do a total hip replacement in our state of Kerala, how he was the first to do an anterior approach vertebroplasty. Those were the things that were most meaningful to him. And he talked for about half an hour non-stop. At the end, he said, what have you done to me? I have not talked about those things even to my wife. What am I doing? I only allowed him to recount the positives in his life. I did not preach to him. I did not ask him to think of positive thoughts. I asked him for his good times. It doesn't last forever, I know. But leaving a legacy, thinking about the meaning of life, those things may be most important in spiritual support. Without saying those words, I was telling him, your life was good in so many ways. Congratulations on your achievements. And validating their successes, their positives, is the most important part of spiritual support. And all these friends has to be integrated into palliative care, into health systems at all levels, across the continuum of care, from the beginning of the suffering to the end. Of the, how many of you are here? I saw a number of somewhere close to 50. Of all of you, oh, 62, so many joined. Some of you may take on palliative care as full-time work, but I suspect that many of you will be doing palliative care as a part of your routine work. The obstetrician, the general surgeon, the gastroenterologist, all will be applying the principles of palliative care, whether you are in a primary care center or in a big medical college hospital, and you would attempt to do it from the time of the beginning of the suffering. When you are saying you have some symptoms of the beginning of dementia, from that time, it has to be application of palliative care in everything that you do. Integrated into all palliative. For example, in the case of cancer, every oncologist has to learn palliative care. If it is neurologist, every neurologist has to learn it. Basic principles, but there may be problems that you cannot solve, then refer to a palliative care specialist. And as far as possible, somewhere during the course of during the course, we'll talk about organization of palliative care also and community support. That is, making use of the community support will be essential for you to give psycho-socio-spiritual support and decent end-of-life care. And this integration can be at the level of the national policy. If your whole hospital adopts it, that would be fantastic. But even if they don't, Amy, Neetu, Sandeep, even if the national policy doesn't have palliative care, even if your hospital doesn't do it, absolutely nothing stops you from your own practice being changed. And as the course advances, you will see how that can be done. Specifically in India, so many positive factors have happened. The law governing opioids have been changed in 2014. And during the course, we'll talk about opioid access. And you will then know that India will stand by for you to make sure that you have opioids available in your institution. We will overcome your barriers together. The national health policy includes palliative care, and it's not only in theory, it's actually happening. State level trainers in palliative care have already been trained, and from April 2023, in every state of India, some palliative care activity will be starting with central guidance, provided the state government agrees. I already told you about the National Cancer Guidelines, but also in India, undergraduate MB medical and nursing courses have already included palliative care in the curriculum. New. So all these things are happening. So we have some positive things to look forward to in most of our countries. I see that Christy, are you from Kenya?
Yes, I'm in Kenya,
yes.
but I'm from Congo.
Congo, okay. Sorry.
I'm in Kenya, but I'm
No.
from Congo.
You are from Congo. Kenya has made rapid advances in palliative care, next only to Uganda, but maybe Congo is early days. So Congo will wait for you to go back and cause a palliative care revolution.
Yes, you are right.
So I see that we have some 18 minutes for discussion. I stopped early. Hey, Christy, you have a question there. Oxygen for 10 minutes only? No, of course not. So this is what I do. I'll tell them, we will start oxygen. We'll try it for 10 minutes. If it makes you feel better, we'll continue it. If it does not make you feel better, we will take it out. Christy, am I pronouncing your name correctly? How do you pronounce your name? Christy?
Yes.
Is that how you say your name?
It's not a problem. It's Christophe, but
Okay, Christopher.
English
Okay.
people have difficulties to say
Okay.
to say
Okay.
it.
Okay. Okay. Christopher. Okay, very good, Christopher.
Yes. Okay. Good.
Yes. So you understand what I'm doing. Sometimes the oxygen, if it does not help the person, if the whole big airway is blocked, you can only give oxygen here. You cannot get it to the blood. It's useless. And the patient feels suffocated. They can't even talk properly. So that's why we are saying try it for 10 minutes. If it makes the person feel better, continue it. If not, take it away.
Thank you.
And Harsha Satyamurthy, thank you for your comments earlier. Now it is question time or comment time.
Sir, what should we do after giving oxygen for 10 minutes? The patient is not feeling better.
Oh, we are not going to wait for 10 minutes. Mala, is it Mala?
Kamala, sir.
Kamala. Okay, oh, sorry. Sorry, Dr. Kamala. I'll go back to my screen share and show you the relevant slide once more. Here. There goes. Sorry. 1 minute. Oh, what's happening? Still the same problem. Okay. So we start the oxygen trial and use 2 of these medicines. We would start corticosteroids. Typically in this situation, we would give 8 to 12 milligrams of dexamethasone. Specifically dexamethasone because it is a corticosteroid with least water retention property, least mineralocorticoid action. So we'll give it slowly. If there is a patent vein, we'll give it intravenously, slow intravenously. For everybody's attention, if you are using intravenous dexamethasone, corticosteroids, always give it very, very slowly. It can cause great discomfort, starting with perianal itching and then nausea. So if you are giving dexamethasone intravenously, give it very slow, never more than 1 milligram per minute. And then I'll use morphine. Preferably, I'll use it orally, if not subcutaneously, because I do not want to cause a sudden hike in blood level. So typical dose would be starting with 2.5 milligrams 6 hourly. And between these things and a bit of reassurance, usually they will settle down, the majority. But if it does not settle down, we may give incremental dose of morphine more till the person becomes a little settled down and quiet. And sometimes, if they are very anxious, at that point of time, after giving morphine, we may add a benzodiazepine, a quick-acting benzodiazepine like midazolam. So this means in the context of irreversibility. Now, sometimes following this, the patient may feel better and may be able to continue a little bit of oxygen inhalation and live with reasonable comfort for some more time. Or if it is very severe obstruction or something like that, it may gradually worsen, leading to death. Have I answered your question, Dr. Kamala?
Yes, sir. Yes, sir. Thank you, sir. Thank you.
So this is Amy here.
Hi, Amy.
Relatives insist on keeping them in intensive care because, to assuage their own guilt, or they want care for the patient. Is that justified, or do we try our best to persuade them to take care of the patient in another room?
Amy, there is a theoretical aspect to the answer and also a practical answer. The theoretical aspect is, who is your client? It is the patient. I am your client. It is my right. This is my body, Amy. I have more right over my body than anybody else. You should be ethically doing the best for me. But you also need to be practical. Amy also is intelligent and would know that once I am dead, I am not going to take her to court. Amy is also intelligent enough to understand that my family will live and may take her to court. So not respecting the family's wishes is not practical. So, Amy, what I would do is, okay, we will talk about it. Let me give him these 2 medicines. So you give me those 2 medicines, take my family to the next room and say, you were asking about ICU. Do you want to tell me why? And most of the time, if somebody asks for ICU, there is at least one doctor or one nurse in the family. Then we are not likely to win. But most of the time, we are able to make them understand. But it is something that you negotiate. Even if you take him to ICU, if you have a high dependency unit, that is short of Pakka intensive care where a family can be allowed in, that would be the next best thing. If at all possible, I would like a family member there. In our country, almost invariably, families are not allowed in ICU. Things are changing in the Western world. In, say, for example, in the United States, now data show that 27% of, this was 5 years back, all ICUs encouraged a family member staying with the patient. They even had a couch for the family member out beside them. It would have been fantastic. Dr. Joel Thomas asks, would you evaluate for the cause of the breathlessness? If so, to what extent? Oh my God, absolutely, absolutely. Dr. Joel, you have brought a very important point. I have not discussed breathlessness in great detail. Sridevi, will there be a session specifically covering breathlessness?
Yes,
Huh?
sir. Yes, we have
Okay,
sessions covering all
that
these questions.
if I go
Dose,
into
and everything.
then Sridevi maybe cross with me if I do that in detail. But Joel, absolutely. Now, that's Joel's question. Is it Joel? It is Joel's question, isn't it? Yes, very important, because I shouldn't make assumptions that it's terminal. And I just do a physical examination and find that the person has a pleural effusion. I tap it and the person breathes well. Or there may be exacerbation of a long-standing COPD. And I use the bronchodilation and that may improve things. So thank you, Dr. Joel. I was only talking about advanced incurable metastatic cancer without chance of improvement. Otherwise, absolutely, yes. And was there some other chat questions? How many milligrams? Okay, Christopher, that will be dealt with later. But ordinarily in this case, thank you. Two questions there. The dexamethasone dose may be a bit variable, but in this context, I might be using as much as 8 to 12 milligram dexamethasone. And that means, as I said, it has to be given slow. Take 10 minutes over it. Otherwise, patient, you will make the person uncomfortable. And why not prednisolone? So then Christopher very kindly tells the trainee, young man or young lady, that is because dexamethasone is the corticosteroid with least mineralocorticoid action. Mineralocorticoid action means it helps with salt and water retention. In this case, our purpose is to reduce the peri-tumor edema.
Yes.
We don't want water retention there. That's a disadvantage. That's why we choose it. Hey, no more questions about breathlessness. There's a separate session on breathlessness. Sridevi is practically threatening me. Hi,
There is
Harsha.
another question where to start reading.
Why don't you, Harsha?
Just one question, sorry for interrupting. In your life or practice or the experience as a palliative care master, have you faced any backfire from the patient's relative who are least educated that the patient has no coming back and the patient collapses in the time when we are unable to explain to the relatives and the time is very short? Have you had any experiences like that? Thank you.
Sure, Tino, thank you for the question. Let me tell you this also. If the patient is coming into the casualty, you don't know anything about the patient, we may proceed with some resuscitation because we don't know. When we know, we should initiate the conversations later. Tino, interestingly, it was not from illiterate people. The fight back has always been from very affluent, educated people who are more afraid of death. The common village folk are familiar with death. They know. It is a city people, urban population, young people in nuclear families who have never had an acquaintance with death, and their families who have this thanatophobia more. And they are the ones who argue. And I'll try to avoid an argument. The only time when somebody was very angry and shouted at me was a medical student about her mother who was in denial, could never accept the mother's death. Though she had a prolonged, horrible 6 months process, eventually when the daughter was very angry that you were all non-caring, etc., etc., that's a natural anger. When you later on have a session about communicating bad news, you will also be told how families respond. denial, anger, bargaining, etc. And we'll also talk about how to deal with that anger. Sridevi, can you find the link for the Indian primer from our website? Harsha Botra is asking.
That will be shared with them, sir. That will be
Okay.
shared with them.
Shared already with them or going to be shared?
Sripriya, have we shared the Indian primer and the robot primer?
No, ma'am, we'll be sharing it along with the other learning materials of this session.
So, I mean, you mean today?
Yes,
So-
after the
Yes, we
session,
will
it will be
provide
uploaded in the LMS platform where they access for the links. We are
No.
sharing several
Sri.
articles also.
Sri,
Yes, sir.
when can they have it?
Sir, I am uploading it in 5 minutes. Just can
Okay.
access.
Okay. So there is an Indian primer there, which you can access. That will be a good one to Harsha to start reading about palliative care. Harsha, you had a chapter in PG. Oh, very good. That's something new. Excellent. Most of doctors in this group wouldn't have had that. Dr. Shivam. So, Shivam, the 2.5 is only the early dose. The further management of breathlessness, Shivam, will be dealt with in the session on breathlessness, more in detail. This is one of the commonest symptoms, most distressing symptoms of advanced illness. It will be dealt with in detail. Thank you for the question, Shivam. There. Indian primer soft copy is uploaded and available in iEcho. Thank you, Sri. We have 1 minute for the last question. All questions exhausted, Sridevi. Sridevi, can I leave you now?
Sure, sir. Sure. We'll take
Okay.
it.
Okay. Oh, friends, so I'm so glad that I had the opportunity to meet up with all of you on the first day. I hope you enjoy the course. I hope it helps you with your routine practice. And all the best to you. So they will continue the session. Thank you very much.
Thank you, sir. Thank you for joining.
Thank you so much, sir. So, as mentioned during the intro part, we'll be having every day, we'll be having a case presentation from the participant side. Because this is the first session for this batch, we'll be doing the case presentation from our side and we'll have a discussion followed by that. And in the end, maybe 5 minutes we can spend on if you have any doubts regarding the session or the presentation. Right, Sripriya, we can spend 5 minutes on that, right? Before the program.
Yes,
ends today. So we'll have the case presentation from our side. This is just a demo part. You already have templates. So this is how we expect you to come up with a case presentation. It should be in alignment with the topic for that day. For example, if you are discussing communication session, you should be coming up with the patient story where you felt difficulty in dealing with communication or felt difficulty in dealing with the pain, so that it will be in alignment with the session that the topic that we are dealing with that day, and the expert will be giving their inputs, your peers will be giving their inputs into that. And during the case discussion, it is not just asking questions and getting the inputs from the expert, rather it's a interactive learning process. Many a times we have learned more from participants because they'll be working in you all will be working in a different setting, different parts of the country. So the experience and the way you manage is very different from what we do maybe. So it's a mutual learning platform. We take inputs from you all. So it is not just giving answers by the experts, but it is from learning from everyone in this group. So, and then I'll go to the case presentation. Just So here I'm talking about the story of a patient, a 39-year-old male patient with traumatic quadriparesis, and he with a stage 4 pressure sore on the sacral and the left gluteal region. Next slide. So this young man came to us in the clinic with 2 days of constipation. He had bed sores over the sacral and the gluteal region, and he complained of moderate pain over the hip region, and he had leakage of urine. So this person, this young guy, had a fall while carrying weight, followed by neck pain and weakness of both limbs, and he was diagnosed with having traumatic quadriparesis in 2015. He was admitted in the government hospital and was discharged after 1 month. After 6 months, he developed a bed sore over the sacral and the gluteal region of stage 4, which is the very, very deep wound exposing the bone. There was history of pain over the hip and the wound site for more than 2 weeks. And pain over the hip region is 5 by 10, 5 out of 10, which is the numerical rating scale for pain, which was intermittent burning type of pain, which is bilateral. And on the wound site, he had pain 4 out of 10, which is continuous probing type of pain. And due to this, sometimes they keep the wound open, which is a general belief in many places that if you keep the wound open, it will heal faster. If you keep it closed, then it will take time to heal. So they kept it open for many days, especially when he has this discomfort. He had a disturbed sleeping pattern and has decreased oral intake. Next slide. This is his general examination. He's conscious oriented, normal temperature, pulse, respiration, and BP, and generally other systems, cardiovascular, chest was clear. And regarding the pressure sore, while examining the pressure sore, there was warmth and tenderness. There were exudates present. Tunneling is the narrow area which increases the depth of the wound from the border. So we may not see the tunneling in the first hand unless you examine the wound thoroughly. It may look like a stage 2 or 3 wound, but with the tunneling, it can be a very, very deeper wound. The wound was irregular in shape and there was foul smelling. Routine investigations were done, which is pretty within the normal limits. Right. So coming to the psychosocial aspect. So he is an unmarried man living with his elderly mother in a rented house. He has a brother, but he is married and living separately and not really involved in the caring part of this patient. And he was a manual laborer and was earning something for the family, for his mother. Now the mother has to go for work. In Kerala, there is a scheme where women can go for work in a fixed number of days. So she goes for this work and she is taking care of him. Now the main source of income is from mother's daily wages, her old age pension, and some of his friends used to help him. And for the treatment purpose, he has taken a loan of 1.5 lakhs from a private finance. He's a Christian, now unable to go to church. This makes him very sad. He has a cell phone through which he communicates with his friends and dear ones. And he kind of got exhausted and told his mother that I don't think I can walk anyway. So please stop spending money for my treatment. Next slide. So his main concerns were when he came for admission are the pressure sores, the pain, and the financial issues. So to summarize, he's a 39-year-old man with traumatic quadriparesis with bed sores present over the sacral and the left gluteal region with pain over the both hip region. So this will be the discussion points. This is where we expect you to ask your questions regarding the particular scenario. So my question towards this group is that, do you think this young man needs palliative care? Does he come under the spectrum of palliative care that we have been discussing in the intro part? And what can be the issues, other than what I have told, what can be the issues that is faced by this patient, and what all should we do for this patient? Just to mention before getting onto the discussion part, we encourage you to start mentioning as patient story, because case is something very dehumanizing. People don't take it really well unless if you ask them. And the case is something which you put things and carry, right? That's what we call as a case. That's the real meaning. So it's a little dehumanizing. So we prefer to mention it as patient story, not a case, if at all possible. There are some instances if you're teaching your students. So it's a good practice to start addressing them a little differently. So over to you all participants. Do you think this young man comes under the spectrum of palliative care? Do you think he needs palliative care? If so, how? And what are the other problems that he might be going through? I'll stop talking and I would love to listen from you all. I got one response from Dr. Satyamurthy that he agrees that he needs palliative care for bed sores should be attended to give him a better relief. So most of 2-3 of you are agreeing that he needs palliative care. What about others? Is there anyone who feels that this need not? I mean, there is nothing. There is. It's okay to tell if you think that he doesn't need palliative care. Thank you. He needs, as he is suffering. Thank you for those responses. He needs palliative care for bed sores in all aspects, clinical, spiritual, and his family. So most of you agree that he needs palliative care. That is one important message that we need to take back home, because many a times when you talk to your colleagues, about quadriplegic and giving palliative care, that may not really work well. They generally ask, oh, this patient doesn't have cancer, but so why do you need to give palliative care? That's still the question that we hear these days. Like the moment you ask to help a patient somewhere, we ask the doctor, okay, there is one patient with an advanced neurological illness. Can you help with palliative care? They ask, okay, why? But he's not a cancer patient. So I'm glad that most of you have understood that it is not just restricted to cancer or people who are dying, but it is also for anyone who is having a serious health-related suffering. If he is the only earning member, his family also needs support. Very true. As Dr. Rajagopal mentioned in the beginning, palliative care is not just for the patient, but it is for the patient and the family. Why do you think that the family needs support? Just questions to everyone.
The family would be educating regarding the patient's condition and how long it can last and what kind of social support the patient will require, or maybe educate the family about what the patient is psychologically going through, so that they can at least support that aspect if they can't give him the best treatment, or maybe if the disease is not curable. So that and whatever activity the patient was used to before falling ill, if that can be substituted in some way, or at least the feeling of hopelessness and uselessness can be mitigated, and if the family can help with that.
Thank you, Dr. Priyanka. As you rightly mentioned, when someone in our family is sick, even with fever, right? If one among our family member is down with fever for 2 weeks, we literally suffer. We can't go for job because we have to take care of them, and you'll be frustrated when you are at work. And what about this kind of patients who have to go through this for the entire life? The caregiver burden is something which we don't really address many a times when they come to a hospital. And we have had instances where the caregiver becomes sicker than the patient over a period of time because they stop taking their medication. So in our enrollment form, when a patient is coming and registering with us, there is a separate page for the caregiver's medical history. Because many a times we have seen that they might be hypertensive, they might be diabetic. And one fine day they just faint. Okay, what is it? Then they say, okay, I have been on insulin for so many weeks, but the priority is now to take care of my husband. So I stopped taking it. Or the money goes to the treatment of the patient, not for the caregiver. So generally they stop taking all these medications. Their sleep will be impaired. So what happens is that many a times they fell ill than the patient. So that's unless you ask them, are you also taking some medication? They won't tell you that I am also a patient or I am taking this medication. So it's very important to ask those questions and to ask what they just want to talk about it. And they will have a lot of guilt in admitting that they are being burdened. They'll be they'll be too much into caregiving. They might be losing their sleep, but they don't want to discuss it with you, right? It's a matter of guilt that, oh no, it's not a burden for me, but I'm exhausted. So these kind of questions we need to ask to the patient's family members, and to, as you said, to prepare them for what is going to happen. Okay, well, how much we can achieve. If not walking, what can be done? It is little difficult with the quadriparesis because the hands are also affected. But at least many a times what they say is, at least if I can turn to one side to the other on my own, or if I can just change, I mean, do something like this person, someone has given him an old laptop. So he mixes music, different songs together, and send it across to people. So all those things. So whatever he can do with the limited activity, he was finding it quite meaningful. He was finding it so good that, I mean, no one wanted that music, like, but the friends were encouraging him to do it, and we'll buy the CD from you. So all those things were happening with him. And yes, Dr. Kalyan has mentioned the problem now is more than the bed sore and the quadriparesis. Yes, but many a times they get depressed because of the bed sore. They think that, okay, my body is getting eaten up by something, so probably I may not be able to live longer. So all these things, bed sore has a bigger implication that we think, not just as a wound, it has much bigger implication in someone's life. I can see a question, Dr. Shakina. If a condition has a cure, can palliative care be an option? I would like to open that question to others. What do you think? It's a very interesting question. Very, very interesting. What do you think, others? If it is curable? Sorry, I couldn't hear. Is it my network? I'll just switch off my video so that it is me. I can see a few response. It has a role. Dr. Sandeep, would you like to tell why you say it has a role? What is the role? Just curious to know.
All the disease along with the curative aspect always involve the, like, some of the issues to be addressed, like the pain, psychosocial aspect, emotional aspect. It includes all those things. It is not just cure of the disease which is having. It is about it involves a team effort.
Thank you, Dr. Sandeep. And there is another comment from Dr. Meera telling that palliation can coexist with curative treatment. I completely agree with whatever you have been discussing. Even if it is a curable disease, the suffering is there, right? So I think palliative care, yes, that's what. So imagine that someone diagnosed with a very curable stage 1 or 2 breast cancer, no metastasis, nothing. It is reasonably good. It has reasonably good curative rate, but still they might be going through a lot, right? The moment they hear the word cancer, the life changes to upside down. They don't know, okay, they might have heard it in movies, or the neighbors might be telling them, oh my God, people die out of cancer. Or sometimes they say, okay, you have to go through a radiation. It is a current shock. It can actually burn your, so many questions, and pain and other symptoms. When they are going through radiation or chemotherapy, there can be symptoms like nausea, vomiting. They get scared and they don't go back to treatment. So if you integrate the supportive care right from the beginning, even if it is curable, there is a high chance that they may continue with the curative treatment, because there is a whole team supporting them to go through all these symptoms, right? Why do people get scared of all the treatment and disease? It is basically the symptoms. They are not scared of the disease per se, they are scared of the symptoms. So if you give an assurance to manage their symptoms, support them through the illness, there is a high chance that they will continue with the treatment. Otherwise, it's very difficult to have that journey alone. So thank you so much. I think Shahina's question was answered. Yes, even if it is curative, palliative care has a definite role, but the role decreases once the cure gets done. When they are cured, maybe your role decreases. If it is progressing, then the role increases. That's the only difference. And yes, psychosocial part plays a very important role, but it is not just psychosocial. It is also about managing pain and other symptoms, and psychosocial plays the major role because it has a huge impact on how patient present to you. The patient with the support system the presentation will be different from patient without any support system that you might have seen in your own practice, whichever specialty you are. Like if your patients have a good family support, they come with the family, they have people around, they generally are uh, uh, they generally are happier and accept treatment in a better way. But when they are alone, abandoned by the family, no money, no one to talk to, then the symptoms will be very, very difficult. So it has a major role in palliative. Thank you so much. What should be done for this patient and his mother? Any idea? One thing Dr. Priyanka mentioned was to give make him do something which makes him feel meaningful. He's contributing to the family. Anything else that you want to add? Yes, Shahina, please.
Ma'am, self-motivation and self-empowerment can be given for the patient. And yeah, how he can motivate himself so that he will have a positive attitude.
Thank you, Shahina. Yes, very true. It's important to understand what is that he has. Everyone has some capability or the other, right? Everyone. There will be one thing that they'll be good at, much better than us. So it's very important to identify what is that in them and to encourage them to. Might be something very different. We may not even think about it, right? So it's about motivating them. How will you motivate? It is very important to involve the peers, the support groups. If there are people already on wheelchair who are doing well, when you tell about motivation, generally, I have heard it multiple times from patients telling, you can tell all those because you don't have the illness. You are not on wheelchair. You don't understand what I'm going through. You're healthy enough to tell all this, give the advice and everything, right? So it's always good to have someone with whom they can relate, and then they talk about. So the support group is very, very important. They may share simple things like, oh, I had a problem with this particular wheelchair. I had problem in shifting, but then I added this particular rope I could hold and got onto the wheelchair. So why don't you try that? So all these things come from themselves. So they find it more acceptable, like how they have done their journey, sharing that journey is very, very important. Vocational help and financial support with the help of NGOs. Thank you, Dr. Kamala. I think it's very important to understand a lot of government schemes, right? There are many schemes in place which many of us are not aware of it. It's very important to link them to those kind of schemes which can give a little bit of financial support, not completely. But yes, there are a lot of NGOs, so collaboration is very, very important. Wherever you are working, it is very important to understand which all NGOs are working, which all field, so that you can get anything else. What about the bed source? How will we manage the bed source? Does he need admission to a hospital, or do they have to hire a nurse to do the dressing?
Dressing can be taught to a family member, and
yes, Dr. Priyanka, please go ahead.
Dressing can be taught to family members instead of hiring someone, because this is a, I think, low socioeconomic family. So anyways, it will be difficult for them to pay.
Thank you. Anyone else? Sorry, Felicia.
And all precautions and lifestyle changes or positioning, etc., can be taught, which will facilitate healing.
Yes. Thank you. And Dr. Shivam, please.
Ma'am, we will do bed sore grading. Firstly, we will do with the bed sore grading.
You mean we'll do the grading of beds?
Yeah,
right?
ma'am.
What are the fees?
After that, we will decide what will the best for the patient.
Yes. And how will we do the bed sore? To take care of the bed sore? Do they need
Firstly, we will do the bread and scale. With the help of bread and scale, we will grade the bed sore, and we will do Maxep dressing, and all other dressing materials are in the market. Very advanced techniques also.
Thank you, Dr. Shivam. There are a few comments also. Regular change in position, very, very, very important. Application, check for diabetes, frequent change of position. I'm glad that doctors are coming up with frequent change in position. Yeah, platelet-rich plasma, vacuum dressing, yes. We have I'm not going into details. We have a separate session on the wound management. But as you have mentioned, it is very important to teach the caregiver. It is very expensive to hire a nurse or take him to a hospital for a daily bed sore dressing, right? So someone has mentioned giving adequate medical kits to the family. So we encourage or we train them to use available resources at the home setting, how to use it as bed sore dressing, and we will help the caregiver to do the bed sore dressing on their own. Sometimes there are certain patients like with hand mobility is okay. There are certain patients who do bed sore dressings on their own. So it's quite possible to train the family to do the bed sore dressing on a daily basis. So that is the only sustainable thing. They cannot hire, usually, even if they are like from a middle class family, they cannot hire a nurse just to, that is not needed actually. They don't need a hospitalization. So it is very important. And all of you have mentioned about the prevention part. It is very, very important. The moment you discharge the patient from a hospital, it is very important to tell them how to prevent bed sore. Generally in palliative care, we get patients with huge bed sores because no one might have told them to change their position. They're supposed to be patients, right? They have to lie down without doing anything. So the orientation is not given usually in the beginning. So it is very important to tell them how to prevent bed sores if you are seeing patients without bed sores also. So I'll stop my continuous speech here. Thank you so much for the wonderful interaction from you all. And next week onwards, it will be the presentation from will be from your side, and we'll discuss. We'll get to see how many inputs you got from the other participants, right? The faculty doesn't have to do much. It is about mutual learning. So this is what we encourage in the coming days also. We have 5 minutes. So if you have any questions regarding the general conduct of the session or I am sure Sweetya has mentioned everything in the beginning. We just shared in the WhatsApp group also. But if there are any questions, we can quickly take that before before ending today's session. If there are no questions, probably, I think we can wind up today's session. Please go back and access to the materials that we share. And if you have gone through more reading materials, you can share it in the WhatsApp group to others. We can all learn from each other. Whatever, if you want a specific topic, you want to know more, you can just write to us. We'll try to share whatever resource or website, and click on resources. We'll have many more important resources there. As we move towards the future sessions, we'll be telling the access to the resources which are available in the Palliative website. So thank you so much, everyone, for the interaction, and Sweetya, over to you.
Thank you, ma'am. Thank you, everyone, for joining in on time. And we do hope that as we move along in this course, everyone is enlightened with the knowledge required to provide palliative care and pain-free lives to people around you. And we do have a feedback form also, which will be shared in the WhatsApp group right after this session ends. So please do remember, please do take out some time to share your feedbacks, because it is very valuable for us to improve ourselves. So with a positive note that we'll be seeing again day after tomorrow with another interesting topic and yet another eminent faculty. This is Sri Priya along with Dr. Sridevi Warrior signing off from the Tips Echo. See you in the next session. Till then, everyone take care. Bye.